We got another girl.
Yeah, well, this one starts out good morning. Maybe we'll pretend she's from Australia. My boyfriend has been using steroids for about 3 years now, and our sex life became almost non-existent. There we go. Back to what's the point then? Right? We went from having sex several times a week to now maybe once a month.
Ouch.
Add another ouch, yeah. He gets erections but doesn't attempt to have sex with me and claims he doesn't even think about it. He also has severe acne all over his face and back, and when he had his blood checked a couple of months ago, his estrogen levels were through the roof, but the doctor didn't suggest anything other than to stop taking steroids, which I don't think is possible for him, nor does he want to. Honestly, I don't know if he truly knows what he's doing when it comes to steroids. He follows whatever different people tell him, but still doesn't get the results he's looking for. This is what he's currently taking. Testananthate, 500 milligrams per week. Deca-Durabolin, 300 milligrams twice a week. Winstrol, 25 milligrams, 1.5 tabs per day. Arimidex, 1 milligram daily, and tamoxifen, 20 milligrams once a day. Is this combination, she puts in quotes, normal? It depends on how you define normal and what group we're talking about. Does he need to remove or add something? I just want our sex life back while he isn't bothered by it and just wants to see results. I feel like he needs to be under a physician's care who understands people who use steroids and can lead him in the right direction, and he agrees. Hope you can help us. Thank you in advance to NDP. I got to state right away, he needs to be in a doctor's care. I'm not the one. I can't do this in this manner. I can only give you general advice. And my first advice would be, please find a doctor who can address this and, all the circumstances, meaning knowing everything about your boyfriend and what's going on. That's my first advice. But in general, responding to this, it's interesting that you said that his estrogen levels were through the roof, and yet he's taking 1 milligram of Arimidex daily. That's probably the most important thing, because in looking at the protocol he's on and the complaints you're telling me about, now I'm assuming that you are interpreting this properly, and I don't mean to be anything but just straightforward with this. The fact that he's getting erections but doesn't feel like engaging with you is kind of strange. But assuming that he isn't thinking about sex and that your interpretation of all this is correct, it's odd that his estrogen is this high given what he's taking, because I would think that it would be actually lower than, we have to be careful too, because are we talking about estrogen? Because I think we've identified about 25 of them. Or are we talking about estradiol? Are we talking about estrone? That's important to note, because we used to use estradiol as a surrogate for all the estrogens until fairly recently, in the last couple of years. Joe and I, Joe's the other physician here, noticed that we had a patient that was getting symptoms despite his estradiol sensitive being controlled, and where we know is I think it was like 17. It's fluctuated depending on the labs between about 11 picograms per milliliter and 17, and that's pretty much ideal. Yet he was still having excess estrogen symptoms. Well, we checked his estrone. We had to get a sensitive estrone. That was the trick. And the estrone was definitely way above normal. So, everyone's different. That can still effectuate problems. So we had to find a way to adjust that, and I'll spare you the story. But we have to identify the estrogen, because it's, typically what you're describing, no libido, comes from over-suppressing estrogen. Typically, you can still get an erection. It's more variable what happens with excess estrogen, but I would think you would have other symptoms, including, not always, but oftentimes gynecomastia, a lot of excess water retention, moodiness, irascibility.
He's got acne.
You can get acne, although, again, it's attributed to dihydrotestosterone. But yes, I've seen it where, despite what we know from our dermatology studies and classes and whatnot, excess estrogen tends to be an issue with acne sometimes too. Although, again, we don't have studies that say, oh, sure, that's definitely what does it. It's just that's more anecdotal evidence. so to jump back a second, is this combination normal? That's a really hefty dose of anabolic steroids. I would argue that definitely not the safest program. You're using two very anabolic substances in decadurobalin and winstrol, very high dosages. Now, I wouldn't be surprised by the estrogen levels being high if the Arimidex dose was lower and you were still using tamoxifen, because remember, tamoxifen is a SERM, it's a selective estrogen receptor modulator. It's only blocking at the receptor. So we'll see elevations in estrogen, but they're not functional because they're not getting to the receptor, right? The tamoxifen is there. But the effect is the same. So bottom line is, what I'm looking at here is still what I think most likely to be occurring is oversuppression of estrogen.
Yeah.
The Arimidex apparently isn't enough, which is surprising, but everyone's different. So it doesn't give an age, but I'm going to assume this guy is probably fairly young. He's definitely not my age, maybe like 28-ish rather than 58-ish. And so he's probably aromatizing a lot more than the average person. Because decadurobalin, I think Llewellyn stated in his book that decadurobalin, although it's said to not convert, it actually in reality about 20% of it converts, but that's still not that much. Winstrol definitely doesn't convert, but that testananthate, especially at 500 milligrams, on top of everything else, is probably all converting, or a lot of it converting. And so that's what the problem is. But with the 20 milligrams of tamoxifen, the estrogen might assay is high, but it's not functional. So the other part of this that's odd, and again lends me to believe that he's fairly young, is the decadurobalin dose. Again, assuming all this is real stuff and not, something other than what it says it is. 600 milligrams of decadurobalin could lead to erectile dysfunction because the nandrolone is what it is. It's the brand name, which is no longer. I mean, we know it is decadurobalin. I think they stopped making it in 94 as the brand. It converts to dihydronandrolone, and that's something that's very, very weak compared to dihydrotestosterone. For a lot of people, that'll lead to ED. So she says he's still getting erections, but no libido. Again, this, to me, if I had to boil this down, I'd say the suppression of estrogen, not its creation, but the blocking of it, or the combination, is leading to a lack of libido. I don't know what else to suggest other than, you got to have a talk with them. I mean, this is, it's a two-way street.
Yeah.
I mean, this is getting into psychology and all kinds of stuff that we don't deal with here. But once a month, that doesn't sound very fair, especially if you guys are both young.
Yeah.
And if it's not suiting you, period. But I would go see a doctor who knows about this and find out more specifics. And again, consider some of the assays I mentioned, not just an estrogen assay, and see if you can't find maybe a lighter dose. And by the way, for the acne, it may be from, it may be from the conversion to dihydrotestosterone. Remember, we talked about that in another question about dihydrotestosterone is pretty much considered the main culprit in acne. If it's in your genes to begin with, it exacerbates it. So you've got the dihydronandrolone there, which displaces the dihydrotestosterone. Acne should be less of a problem. Normally, I would recommend using a 5-alpha reductase inhibitor, right, so that you don't create too much dihydrotestosterone from the enanthate. When we're dealing with decadurobalin or nandrolone, it's the one time that a 5-alpha reductase inhibitor is not what you want because of what I said. It converts to something less strong. Dihydronandrolone is less strong in terms of activating the genes for acne than is nandrolone itself. So decadurobalin, nandrolone use is the one time you don't want to use a finasteride or dutasteride. So look at the estrogen levels, look at the dihydrotestosterone levels, and see what's going on. And then you can always treat. Now we're going way beyond what we normally do, but can't help myself. Doxycycline for a month or maybe more is a typical treatment for acne, 100 to 200 milligrams a day, to try and get it under control. And sometimes that's enough. When it gets out of control and the bacteria, have the edge on the face or the back or wherever it is, sometimes you got to beat it down and then control some of the other exacerbating factors and get it under control. Topicals are also, the benzoyl peroxides of the world and maybe Retin-A. Those can help. But yeah, I would get some professional advice. This is a lot to digest and try and figure out.
Yeah. Thanks, Doc. Hi, Doc. What next?
This one starts, hello, Dr. Rand. I guess you're chopped liver today, Dave.
That's okay.
No, hey, Dave.
You're the star of the show.
I'm the star. Please let me ask this question. You just did. If someone is using Concor 2.5 milligrams, Concor is a beta blocker. It's used for the heart. And in his case, 1 tab a day for his hypertension. Can he still use anabolic steroids as follows? 2 milligrams test enanthate, 251 per week. I think what this is 2 milliliters of test enanthate, 250 per week, and 60 milligrams of anavar per day. Or this might cause adverse effects and he just have to quit. Well, this is kind of a loaded question. If the question is a beta blocker contraindicated with use of an anabolic steroid or vice versa, or even testosterone replacement, no. You definitely want to keep your hypertension controlled. And if it's psychogenic, meaning if it's, a lot of people can have elevated blood pressure for any number of reasons. Think about it. We all have some sort of psychogenic hypertension. I wouldn't call it hypertension, but elevations of blood pressure. I joke with guys all the time. Hey, man, if your blood pressure is 180 over 130 on your way to the gym, turn around and go home. You're not ready yet, man. Get psyched up. Just getting ready to do your deep squats should get your blood pressure up, right? But in some people that tend to be high strung, tightly wound all the time, then that's what we would call psychogenically furthered anyway, hypertension. And a beta blocker is something that blocks your sympathetic nervous system, so that fight or flight response, so it can tamp down the psychogenic component of hypertension. That exacerbation of something that might be high for another reason, like a blocked artery, particularly a renal artery. But so you might see some bumps in blood pressure. So say someone has it controlled at 120/70, they go on Anavar, especially 60 milligrams a day. We'll get back to that in a minute. And they might be a little more amped up. So it will leverage that psychogenic component that they naturally have, and you might see it bounce up to 140/90. Now, the question is that a problem? Yes and no. We know what it's from, right? Just like we know what it's from when it's 180/130 and you're going to the gym and working out, right? But if it's chronic, meaning there's no time for it to go back down, like it does when you're otherwise normal and going to the gym, and after the gym it comes back down, then it's a problem for sure. It's also a problem if you have, say, an aneurysm, aortic aneurysm, where you have to have it down all the time. Otherwise, an aneurysm is something where, think of it as a balloon, and like the clowns make, you can have a little area of the balloon that gets a little more puffy than others. Well, the balloon is thinner there and can burst. So there, you don't want ever have too much blood pressure, so that can contribute there. So you see where I'm going with this, where it depends on the reason you're taking the Concor and reducing your blood pressure using a beta blocker, which is also a unique way of doing it. But because it's a sympathetic nervous system blocker and Anavar tends to ramp you up, it might be counter to this medication more so than most. But as a general rule, okay, we're going back to general rules, it shouldn't be a problem, because if there is a little bit of bump and there's no fear in having it temporarily bumped up, we know what it's from. As soon as you go off the Anavar, it'll come back down. And just like with anything, we've got people on TRT, we've got people that are on TRT but have naturally high levels of testosterone that have hypertension, and we just treat the hypertension.
Yeah.
You follow? So I would definitely run it by the doctor with whom you're working to control the blood pressure and find out if this could be a problem. But just on face value, it's not contraindicated, but it may be something you choose not to take because of other reasons. Now, the other thing is that's a pretty hefty dose of anabolics. I mean, 60 milligrams of Anavar a day, I think we might address this before. They used to make, GD Searle manufactured it starting, I think, in the early 60s. And Anavar is still made in 2.5 milligram and 10 milligram tabs. Okay, and depending upon what literature you read, you could argue that certainly for a male, I'd say max dose is probably still listed at 30 milligrams a day, and it's got a very short half-life. So you take like 3 10 milligram Anavar a day. To stack it on top of something else is obviously going well above that dose. And if you're truly getting pharmaceutical grade Anavar, the real deal, 60 milligrams is a lot. I had a fellow come into my office one time, and he was sweating and very nervous and blurted out pretty much from the get-go, Rand, what do you think I could have been given? I was told it's Anavar, but I feel like I'm jumping out of my skin. I'm sweating. I feel like my blood pressure's up. I'm nervous. And I said, well, what dose you taking? And he said, well, they're 100 milligram caps.
Oh, jeez.
And I'm thinking, well, yeah, that could be a problem. And I think we've talked about this before. A glass of beer is very different than a glass of rum, 151.
Right.
It's still a glass, equal glass to glass, but very different substances. So don't get caught up in the milligrams.
Yes.
60 milligrams of Anavar, bottom line, is a lot of anabolic steroids, especially this particular one. And I would argue that if it's truly what it's supposed to be, you don't need that high a dose. And ditto for the testananthate. Typically, 1 milliliter of 200 or 250 milligrams of a test ester is fine. Testosterone ester is fine. To go to 2, again, we've addressed this before, it's kind of like putting more unleaded fuel in the tank. Only so much can go in the cylinder. You only have so many receptors. So, better to probably, keep the testosterone enanthate at a TRT dose. And then, so that'd be about 1 ml a week, as I stated. And then adding the high test, the premium oxandrolone to that. And again, at certainly, you don't need 60 milligrams a day, especially if this is your first time, etc. I would definitely try using a lot less. So, boy, I talked a lot around that one, but I hope that makes sense. And again, please, address this with your doctor who knows why you're taking a hypertensive medication.
Yes. Awesome. Thanks, Doc. All right. What else we got?
Hey, Doc, I've ran 3 cycles this year, and I haven't taken HCG once. There's no punctuation here, sorry. I hopped off cold turkey. I was taking EQ and Primobolan. Then I took Sustanon and Trenbolone. I just started my third cycle. My first week, I took 250 milligrams Sustanon at 1 cc, mixed with 200 milligrams Primobolan at 1 cc. I did that 3 times, Monday, Wednesday, Friday. I started this because my test dropped down to 260 and my sex drive has been completely low. I just wanted to know how to fix my situation. I just turned 20. I'll pay whatever it is to just fix this issue now. I know you don't get back to everybody, Doc, but please, if you can just give me a little bit advice. I'm new to this and I just got caught up in the gym. I didn't really know what I was doing. Just used everybody's advice and made my own knowledge out of it. Anyways, please get back to me, Doc. Thank you. No name. So, sorry, that was hard. There was absolutely 0 punctuation there. So
I guess you should have watched the video before today.
So I'm trying to understand. The question is, what help can you get to at 20? Obviously, unless you've got a very rare disorder of some sort, you probably don't need to be on testosterone replacement therapy. I am making an assumption, but I think it's a pretty good one. And it looks like this is someone who went on an anabolic steroid and suppressed your own endogenous production for too long, and now you're trying to get out of it. Is that how you're reading it?
Sounds like it to me, yeah.
So I would say in your case, there's a couple choices you have. One is to use the HCG we were talking about earlier, which tells the testicles start working again. And it's a direct order. There are other ways to do that higher up the chain, but HCG, and without going too far afield, is the best and easiest to mimic luteinizing hormone and to effectuate a restart of the Leydig cells. The other way to do it is a little more indirect, and we used to use Clomid a lot.
Yeah.
We can also use Nolvadex. These are both the brand names for clomiphene citrate and tamoxifen, respectively, they're considered SERMs, selective estrogen receptor modulators, because they go into certain receptors in the body and block the perception of estrogen, particularly the pituitary, which is deciding, hey, do we need to send more signals outward or not, based upon the levels of really two hormones, testosterone and one of its metabolites, estrogen. So the jip with the human body, if you will, is that even if testosterone is low, if estrogen's high, your pituitary won't send a signal to make more testosterone. So by reducing your estrogen when your testosterone's already low, as it was in this case, I'm assuming that's 260 nanograms per deciliter of total testosterone, then the body says, oh, okay, well, I'll go ahead and send a signal now because these are both below where they should be. And again, that's an indirect way of getting your body to signal the testicles to make more. The problem with Clomid is it's an isomer of, I mean, it's got two isomers in it, and one of them is zuclomiphene, and it's what we attribute the nasty side effects that can occur with clomiphene citrate. There, as I said, the name is selective estrogen receptor modulator. So the thinking is that, as we all know, estrogen too high in a male, and in a female too, can lead to, we don't have to call them disastrous consequences, but untoward symptoms of, moodiness and irascibility and just feeling not so good. So, and the half-life of zuclomiphene is much longer than its other isomer. Anyway, the bottom line is some people can use Clomid, some can't because of the side effects. Now we have an off-label use. And by the way, Clomid, I think, was used off-label in TRT, not TRT, but to induce testosterone anyway. It's more of a fertility drug. In clomiphene, which is the other isomer in clomiphene citrate, or Clomid, is the one we think works not only as a SERM, but as a SARM, a selective androgen receptor modulator. So it increases in intertesticular testosterone, and both, you could say both indirectly and directly, gets the testicles up and running again. Now, I know that's a lot to chew on, but the bottom line is we have better choices than we did in the past when it comes to just at the level of clinical testosterone therapies. Clomid, again, used to be sometimes disastrous. I've taken it before, and within 4 days, felt like I wanted to jump off a building. It can make you feel miserable. And, you're supposed to be trying to feel better, not miserable. It's not just about getting your testosterone levels up. So Clomiphene presents another option that's a much better option we've found so far. In, I believe it was 2015, it was branded as Androxyl, and it was meant to be part of the U.S. formulary, went through the FDA and got rejected for some reason. And there's just not enough money in it, is what I perceive is the problem at this point for it to bring it back to the market for another try. So for now, anyway, it's available in compounding pharmacies, and again, a much better tool than arguably both Clomid or Nolvadex, the tamoxifen. And either one of those can help get the testosterone levels back. You don't want to go on TRT at this point. You're at 20 years old, the presumption is you can get your testicles up and running again, and either of those two ways should do it, and do it pretty quickly. Again, because you're young, and it doesn't say how long you were on these others, but it's not a matter of the dosing, which is relatively high, it looks like. It's the amount of time that you're on the cycle. So again, I think you should bounce back, and probably, just to give you an idea, within about 6 weeks of therapy, if done properly. And it's okay. You can start with 6.25 milligrams of enclomiphene, and if that doesn't work, go to 12.5, and then pretty much the max dose clinically is about 25 milligrams, either daily or even every other day. Well, the max would be every day, obviously, and see if you don't get a pretty big boost in your testosterone, again, fairly quickly, such that I would say the outside for your age at 20 would be 6 weeks. Now, the only problem with this therapy, you got to do it in conjunction with your doctor carefully, is when you block estrogen to get the signal sent to your testicles, you can block estrogen too much. And the problem with that is it can affect your libido and erectile function. So you got to find that sweet spot. That's why you want to start with what I would call the minimum dose. Typical minimum dose is 6.25, and work your way up slowly.
Yeah.
You should start to feel better with the first one. You can keep trying to find the right dose so it's the sweet spot, the perfect one. But be careful not to go too high and to effectuate an over suppression of estrogen, because then it'll backfire. You'll feel great energetically, if you will, and you get more leverage for muscle mass and whatnot, but then the libido's spent, and then what good does all that muscle mass do you to show off if you can't use it, right?
Not good. That's good advice. Thanks, Doc. All right, Doc, what else?
So next one is, in what quantity may the peptide BPC 157 be administered to right ankle in case person suffers from rheumatoid inflammation of joints and arrhythmia of heart? Is 250 units okay? Or ... Regards, P. Komar.
They must have seen our last video about that.
Yeah.
We talked about it last time.
First of all, you shouldn't have any issue with arrhythmia because of BPC 157. It doesn't make sense physiologically, and I've never seen any studies. And by the way, as we shared, there aren't a whole lot of studies in humans using BPC 157, but it shouldn't affect the heart negatively at all. And certainly an arrhythmia is an electrical issue. So I see no connection with BPC 157 and arrhythmia. As always, I can't give medical advice. We say it up front and at the end, right, Dave?
Yep.
Ask your doctor, but again, it just informationally, it would seem okay. And as far as rheumatoid arthritis or rheumatoid inflammation of the joints, as P. Komar puts it, really not the best substance. BPC 157 is more for soft tissue repair. We went over the whole where it comes from and all that stuff last time, right? So not the best for inflammation of the joints. The dosage, though, 250 units is kind of light. I think the max dosage that we've come up with so far, again, because we don't have human studies, has been estimated around 800 units. And it's actually micrograms. When he says units, first of all, and I got to be careful that I'm glad I caught myself. Units. People are looking at an insulin syringe and saying, oh, well, how many units do I use? These represent units on the insulin syringe. Well, it all depends upon how you mix the substance.
Yeah, exactly.
These are just units on an insulin syringe.
Yeah.
Now, they're designed, an insulin syringe, for units of insulin. That's where you don't have to do any calculating. But for anything else, an insulin syringe is used for, you got to do your calculating based upon what you got in the vial,
versus the water.
Versus the diluent, so 800 micrograms, which is the unit of measurement we should be using here, is the daily dose, which seems to be the dose at which more than that doesn't help you, but maximum dose or minimum dose, I guess, however you want to look at it, but divided. So you might use 400 in the morning and then another 400 micrograms at night. And you can inject it into the soft tissue, again, usually better for tendons and ligaments, or around it. I remember when it first came out, the guys were doing a triangle. So they do two, say it's the bicep tendon, 2 injections on this side and 1 on the other side of the tendon, then flip it for the night dose. But we found if you can do it, and you are doing some damage, if you will, with the needle where you're injecting it, but as long as you can tolerate it, it's better to inject it in the tendon if you can, or the ligament, like if it's an MCL, a medial collateral ligament. But it might get too sore and you say, okay, I'll do it around it. But for rheumatoid arthritis, again, probably not the best. You might want to consider PRP or stem cells for arthritis of any kind. And rheumatoid arthritis is an autoimmune disorder, so there even I would lean more towards stem cell treatment than I would PRP for that reason alone. But I hope that gives you at least some basic information.
Awesome. Thanks, Doc.